Welcome, everybody. I am grateful to welcome you all to our third session on medical assistance in dying, organized by our Professional Standards Committee. And I do want to take this time to begin first and foremost by doing a land acknowledgement and acknowledging that I am speaking from Mi'kmaq. And indeed, the Nova Scotia College of Social Workers is in Mi'kmaq, the ancestral and unceded territory of the Mi'kmaq, whose inherent rights were recognized in the peace and friendship treaties that were signed from 1725 to 1779. This series of treaties did not surrender Indigenous land, resources, or sovereignty to the British Empire, but instead established rules for an ongoing relationship between nations. The treaties were later reaffirmed by Canada in Section 35 of the Constitution Act in 1982, and they remain active to this day. The Nova Scotia College of Social Workers joins our members and our communities in the necessary labor of reconciliation. We are grateful to live and work together as treaty people in Mi'kmaq. Please think of the lands, territories, and Indigenous peoples who lived and continue to live within these lands, and how each of us individually and as a collective body of social workers can hold ourselves accountable to reconciliation with Indigenous peoples here and across Turtle Island. We are all treaty peoples. Walaliu, thank you all. I want to also do a special thank you to all of the volunteers of the Medical Assistance in Dying Working Group Subcommittee of the Professional Standards Committee for all of their time and hard work in developing our standards. And especially I want to thank Dominic Boyd from that committee, who will be helping to facilitate today's session, and our esteemed guest, Professor Archie Kaiser from Dalhousie University, and you will have a chance to learn more from him shortly. But I want to take this opportunity just to remind everyone of our ethical decision-making tool that is available to you all. If you go to our webpage, you will see the ethical decision-making tool that helps you if ever you're struggling with an ethical dilemma. And certainly, as we will discuss today, medical assistance in dying brings up many, many dilemmas. And so you can look at our codes and values and how these are might be playing themselves out. So it's really just a tool to help you think more critically about how to apply the code of ethics. And so it also has, for example, the list of principles of ethical principles and standards of practice. And it's a great resource that we encourage everyone to look at. And it's on our website. So with that, I am going to stop sharing right now. And I am going to invite Professor Archie Kaiser to share a little bit. And as you can see here, he is professor at the Schulich School of Law at Dalhousie, but also cross-appointed with the Department of Psychiatry. And I am really, really grateful to him for agreeing to speak to us, because I had the opportunity of reading some time ago some op-eds that he had written on this topic and was really profoundly moved and inspired by his social justice and advocacy lens, specifically on this topic. So I'm so grateful that we get a chance to learn from him, and I am going to be quiet now.
Well, thanks so much for joining me today in trying to come to grips with the difficult issues that surround medical assistance in dying. Are my slides visible, and am I being heard?
Yes, you're perfect.
Well, I'm not perfect, but thank you so much to the college and to Nadia and Dom, for cleaning up the mess that I may make for you. A minor AV apology. I'm in our new video conference center, and I had thought it would enable me to zero in more, but I'm at the end of this big conference table. As you can see, I'll try not to be distant from my audience. So you can see my title here gives away my editorial stance. It's entitled Medical Assistance in Dying, the Dangerous Trajectory of Canadian Law. And that's exactly what I'm going to put forward for you today with an exhaustive range of sources. As usual, too many slides, too much information, and I'll go through them too quickly. I ask in advance for your mercy and your forgiveness, but you will have a resource at the end of the day, which I think will be usable in other circumstances. So here are the key points that I want to make for you. I just want my slides to change now. There we are. So this is basically what I'm going to cover today. Most of this would be fairly elementary to you. Some of it is going to be more challenging because it's drawn from different legal sources. So basically, I want to help you understand that what you already appreciate, I'm sure, that health inequities continue to grow in Canada, that Canadians with disabilities are exposed to ableism, discrimination, and poverty. That worldwide, and I will bring in a world perspective, the status quo neglects the preconditions of poor mental health, suppresses human rights, overemphasizes coercion and intervention. And we as a country have not lived up to our comprehensive obligations under the Convention on the Rights of Persons with Disabilities, the CRPD, as I'll be referring to it after this. The 21st century's first international human rights treaty that now covers for the first time the interests and rights of persons with disabilities. We did in Canada liberalize access to medical assistance in dying over the protests of people with disabilities in the Carter case in 2015, and we amended the criminal code. And then in 2021, we further amended it to pave the way for what people with disabilities are saying involves discriminatory impacts on people with disabilities, and in my opinion, further potential assaults on people with mental illness in the next 2 years. The 2021 Criminal Code amendments, as I'll explain to you, have been roundly condemned by the United Nations, by Canadian disability advocacy organizations and critical scholars. And in the end, my message is that these criminal code amendments take us in the wrong direction, and we really should be thinking about offering people with disabilities more and facilitated access to death. So the status quo, the social determinants of health, you're very familiar with this, so I don't need to emphasize it to a large extent. We know that one's mental health and mental disorders are shaped by the social, economic, and physical environments in which people live. That's very important for us to recognize, as we look at the issues today. We know that differences in social, economic, and environmental circumstances lead to health inequities. We know as well that social inequality is associated with an increased risk of many common mental disorders. The Public Health Agency of Canada said in 2018, our health inequalities exist, they're persistent, and they're growing. We know that they are the result of relative social, political, and economic disadvantages that particularly affect people such as Indigenous persons, sexual and racial minorities, and many other groups, including those with functional limitations and those who are at the bottom of the socioeconomic ladder. Here's what our Supreme Court of Canada says about the way we have treated persons with disabilities in our country historically. And of course, lawyers like to fetishize what the Supreme Court says. If they say it, it must be true. But it also makes it easier for us when we do litigate cases involving discrimination, because it means this is the received wisdom of the Supreme Court. So it's basically incontrovertible as general principles in litigation. So in the famous Swaim case, which struck down the previous iteration of the mental disorder amendments of the criminal code in 1992, the Supreme Court said Persons with mental illness have historically been the subjects of abuse, neglect, and discrimination, systematically isolated, segregated from the mainstream of society, devalued, ridiculed, and excluded from participation in ordinary social and political processes. And the Eldridge case, another discrimination case, echoed that a few years later. But as recently in 2020, in the Attorney General of Ontario case, the Supreme Court saw fit to reiterate these themes. Persons with disabilities regrettably face recurring coercion, marginalization, and social exclusion. People with mental illness particularly face a prejudiced idea of dangerousness, along with stigmatizing, prejudiced notions that have led to profound disadvantages for people living with mental illness with deep historical roots. Stigmatizing attitudes persist in Canada to this day, and they become central to support for coercive treatments, legislative solutions, and justifications for social inequities and injustices. And I'll also argue that they were central, to our Parliament's indecent haste in creating these new criminal code amendments. We also know, and you better than I teach in University Avenue, in the law school in a pretty rarefied atmosphere, although I have connections to the community, but you who are working on the ground and at the coalface, of social injustice know that there are very high rates of poverty among people with mental health problems and intellectual disabilities. We know that poverty goes in both directions. Poverty exacerbates stressors, and also mental illness may cause slides into poverty. So we know that's the lived experience, particularly of people with mental illness. We also know that our society is terribly infected by, variations of ableism, disableism, or saneism when you come to thinking about persons with mental illness. This is just a form of prejudice like racism or homophobia based upon stereotype, myth, superstition, and de-individualization. It may be conscious or unconscious. It may be embedded in institutions, and I believe it's embedded in our legal institutions and in our parliament systems and in the broader culture of our society. The international community, has started to recognize what I think many social workers already do, but advocates for persons with disabilities certainly do, which is that, there is an intimate relationship between the way in which people are treated in society and the way that they experience, their mental illness in society. So there are special rapporteurs who are appointed by the United Nations to basically report on, we can't say they enforce International Human Rights Convention, but report to the international community and to the United Nations itself about their observations as to what's happening in the world community, but also in individual countries. So the special rapporteur on health, and the right to the highest attainable standard of health is enshrined in several international treaties, has recently issued 3 major reports which deal with mental health issues. 2017, the right of everyone to mental health. The special rapporteur said, current psychiatry has led to the mistrust of many users, to their disempowerment and stigmatization. The domination of the biomedical paradigm has been unfortunate and has resulted in the continuing neglect of the preconditions of poor mental health, such as violence, disempowerment, social exclusion, socioeconomic disadvantage. So that the special rapporteur in 2017 was recognizing that the way we've been doing mental health has failed to understand the social determinants of health. So in 2019, the special rapporteur took it upon herself again, to talk about the role of the determinants of health in advancing the right to mental health, because it's the right to physical and mental health. And the special rapporteur again said mental health has to be defined, instead of using the biomedical model strictly and psychiatric terminology, has to be defined by looking at the social, psychological, political, economic, and physical environment that enables a life of dignity. That's the critical thing. And that overlaps with the CRPD that I was talking about before. So the special rapporteur said, we really need a rights-based approach to mental health, to create and sustain enabling environments. That's really the critical insight that the CRPD offers. So in 2019 says we should instead be promoting community inclusion. We should be eradicating xenophobia, decriminalizing poverty and behaviors such as drug use, moving away from coercive measures. And the special rapporteur condemns structural violence based upon unequal power relationships and social structures and cultural violence, and said that within mental health care systems, that there's an unacceptably widespread level of violence, institutionalization, and other forms of coercion. 2020, the special rapporteur didn't let these themes go, thank heavens, and so that the United Nations was again reminded that we need to fundamentally reorient our approach to mental health as a world community. So the special rapporteur again in 2020 issued the report entitled A Human Rights-Based Global Agenda for Mental Health and Human Rights, highlighting the global failure of the status quo to address human rights violations in mental health care systems, and saying that, and this is very important for what I think is the misguided changes of the criminal code that I'll be talking about shortly. Treatment and distress must be seen more broadly. We must move beyond the biomedical understanding of mental health, because there can be no good mental health without human rights, and medicalization has too long been used to justify coercion. So in 2020, the special rapporteur lamented the fact that research has not been focused on how poverty and social injustice can produce mental distress, and indeed talked about the holy trinity of labels for traditionally marginalized groups, particularly those with mental illness. People are either seen as bad people or criminals, or sick or mad people or patients, or a combination of the two, when we think about people who are in the forensic justice system. So that the special rapporteur says we really need to, as a world community, implement a human rights-based approach to mental health that firmly establishes human rights and social justice as absolute core values. Now, I emphasize that the pronouncements that the United Nations is listening to on where we should be going as a world community first, because regrettably, our own parliament, I don't think, has recognized the need to reorient their thinking on mental health, mental disability, intellectual disability, mental illness, and how people live in our society. Indeed, it's as if they didn't think at all about these determinants of health when they changed the criminal code. I'll mention briefly, another special rapporteur on the United Nations Convention Against Torture, UNCAT, because this report, in 2013, condemned forced interventions in general and urged revision of domestic legislation that allowed for forced interventions. So it too was a recognition that people with mental illness are too often treated with coercion rather than respect for their rights and an understanding of how they're disadvantaged in our society. So the UNCAT special rapporteur then again called for the prohibition, as did the CRPD committee, of disability-based detention and institutionalization and preventive detention. And those are themes, which I think are still echoed in the criminal code. That is an inappropriate conception of the lives of people with mental illness, here offering them the ostensible choice of medical assistance in dying. But it's just a variation, I think, of the misguided thinking that the Special Rapporteur on Health and the Special Rapporteur on Torture have observed. So, the Special Rapporteur, and this is 2013, emphasized alternatives to the medical model of mental health, including peer support, awareness raising, training of mental health care and law enforcement personnel, and the abolition of coercive legislation. I should also mention, and again, living in the international domain, that the United Nations Committee on the Rights of Persons with Disability has the obligation to look at the Convention on the Rights of Persons with Disability as it's been implemented or not by individual nations, including Canada. And it has condemned Canada's, this is 2017, ongoing reliance on substitute decision-making and coercion. It has said that the convention has yet to be incorporated in legislation and policies. It recommended that we change our outlook on the convention and make further efforts to incorporate it into our law. it recognized, that the same truth here that Canadian civil society organizations urged, had to be considered when they addressed the CRPD Committee of the UN. So in July 2019, Canadian civil society organizations together, talking about the CRPD, said that in Canada, persons with disabilities face pervasive discrimination in exercising legal capacity, denied the right to make important life decisions systematically, and that it's denied through involuntary admission and other coercive practice, adult protection interventions, and imposed substitute decision making. The Canadian civil society organizations then communicated in the same manner, to the United Nations that the Special Rapporteur on Health did in general, and the Special Rapporteur on Torture did, that recognizing and demonstrating here in Canada that there continue to be barriers to inclusion for people with disabilities, and especially those with mental illness. They weren't given their rights to choose. They weren't provided with individualized supports. They weren't given the accessibility of community services and facilities that the CRPD guarantees. So, and I'm zeroing in more on Canada now. We know about the world trends. We know what's said about, the international community in general. But we've seen so far then that the UN Committee on the Convention on the Rights of Persons with Disabilities began its negative assessment of Canada in 2017. And that continued, supported by civil society organizations. But here we have the Special Rapporteur on the Rights of Persons with Disabilities, who visited Canada in December 2019, including Nova Scotia and Halifax. And the rapporteur on the CRPD in Canada said that there should be community-based, non-coercive services that are respectful of the rights and dignity of persons with disabilities. We need supported decision-making, rather than substitute decision-making. So, that's what the Special Rapporteur, demonstrated when, she visited Canada in December 2019, that we need to fundamentally reorient ourselves in Canada about how people with disabilities live in society and how they're treated. But, and now this gets dark, or very dark in my view, because I'm going to look at the progression of MAiD in Canada. It really started in some ways in 2019 in earnest, when these provisions of the Criminal Code of Canada were eventually struck down by the Supreme Court. Section 241 previously said you committed an offense when you aided or abetted a person to commit suicide. And Section 14 said you're not entitled to have death inflicted on you, and there's criminal responsibility for the person who causes death despite their consent. It is both of those sections that were struck down, and there are now exemptions for nurse practitioners and physicians who supply medical assistance in dying. But the importance of these provisions are, from the Supreme Court of Canada's point of view, is that originally that prohibition against attaining assistance in suicide and the prohibition against consenting to one's own death left people with a cruel choice: committing suicide prematurely or suffering until death. And they said, that was cruel. So they said it's time for the law to change. So those prohibitions they declared to be void in certain limited circumstances, where the person clearly consents to the termination of life, and where the person has a grievous and irremediable medical condition, including an illness, disability, or disease that causes enduring suffering that was intolerable. That's what the Supreme Court said had to be the framework of the new legislation in 2015 in the Carter case. Even then, before the Supreme Court of Canada, people with disabilities spoke virtually unanimously across Canada. Their advocacy organizations said they were opposed to legalization, even the limited legalization which eventually came, when Canada changed its criminal code at the orders of the Supreme Court. They were opposed to legalization because they said in 2015 it implicitly devalues people's lives who have disabilities, renders them vulnerable to unwanted assistance in dying, rather than enhancing their autonomy and their dignity and protecting them. So they were opposed in 2015 before the Supreme Court. That opposition has continued. The Supreme Court, were presented with the argument in Carter that there's a slippery slope danger here, but they reassured us, I think falsely, that it's possible for physicians with due care and attention to the seriousness of the decision to adequately assess decisional capacity within the framework of the law. So that the Supreme Court then determined that those provisions that I mentioned to you before were void, as they prohibited physician-assisted dying, and they presented this new framework, which is embodied in the legislation which emerged quickly in 2016. The Supreme Court gave a very limited fuse to Canada, to introduce changes to its criminal code prohibitions on assistance in dying. And it introduced the basic changes that I mentioned to you before. It now exempted from criminal liability medical and nurse practitioners who provide MAiD, and it provided eligibility standards under this section. You had to be 18 or over, had to be capable, you had to voluntarily request it, had to provide informed consent after receiving information about ways to alleviate suffering without being too specific. But the Parliament of Canada, when they introduced Bill C-14 in 2016, made this very specific provision of the law, that you had to be in a state where natural death has become reasonably foreseeable. That's the critical thing that was changed in 2021 by the Parliament of Canada when they revisited medical assistance in dying. And I've said before, and I'll say again, and many people would agree with me, that they did it with indecent haste. They did it because of a single decision by a trial court only in the Trushin case, 2019, which declared provisions of the pre-existing law requiring reasonable foreseeability of death and being at the end of life unconstitutional. Strikingly and startlingly, compared to other major human rights decisions, the government of Canada did not appeal this decision. So you had the lowest level Superior Court judge, who effectively spurred the Parliament of Canada to go on. As a legal scholar, I can tell you, I can't remember this ever being done previously on such a critical issue affecting the fundamental human rights of so many people. It shows an enthusiasm, of the government, which is shameful, because it didn't go to the Court of Appeal and the Supreme Court of Canada for their further input. It just said, oh, well, if a judge has said that, then we're going to change the law. So the amendments, which were only assented to a few months ago, in March 17th, 2021, extended MAiD, very liberally to the point where it's intolerable for many groups that advocate for persons with disabilities. Critically, for our purposes today, it repealed the provision that required that a person's natural death be reasonably foreseeable. And it specified that persons whose sole underlying condition for mental illness would not be eligible, but, and this is the big threatening but, unless Parliament takes action, that prohibition on providing assisted death for people whose only problem is mental illness is going to be repealed automatically after 2 years, unless Parliament introduces additional protections for people with mental illness. So that's a battle yet to be fought. If we have the same government in play in 2021, it's going to, in my view, indecently and enthusiastically argue for the provision of assisted death for people whose sole underlying condition is mental illness. To my mind, again, for Canadians and in the international community, we should be ashamed of ourselves that that's what's happening in our law. That's why I say this is a dangerous trajectory. The Bill C-7 did create ostensible safeguards, including those which would provide some protections for people whose death is not naturally foreseeable. And it also provided for some advance declarations that you wanted to have made when you lost capacity. So the international condemnation of Bill C-7 was very quick, very profound, and very powerful in my view. So we had three international special rapporteurs appointed by the United Nations on the rights of persons with disabilities, the special rapporteur on issues surrounding extreme poverty, and the independent expert on the rights of older persons, who chimed in hoping to stop Parliament. But Parliament didn't listen. But this is what the special rapporteurs said. We recall that previously there was, by the Special Rapporteur on Disabilities in her 2016 visit, echoed again in 2019, extreme concern by the Special Rapporteur on Persons with Disabilities about the implications of the 2016 amendments from a disability perspective. That is, the earlier, more restrictive amendments. The Special Rapporteur then said that persons with disabilities might be persuaded to seek MAiD, being offered between choice between a nursing home and MAiD, as their sole choice. The Special Rapporteur had said then that assisted dying must not be seen as a cost-effective alternative to providing personal assistance and disability services. And the Special Rapporteur said ableist assumptions continue to influence important debates that impact the rights of persons with disabilities. And I have absolutely no doubt that that was reflected in our parliamentary debate, that outdated notions about normality still dominate. So they went on to say, with these amendments that were being proposed and are now law, there was a potentially discriminatory impact on persons with disabilities and older persons who are not at the end of their lives. They felt that it would violate the rights of persons with disabilities to life. They said it was contrary to Canada's international obligations, inconsistent with our CRPD obligations to combat ableism and to secure equal respect for rights. Those are themes which have been brought to the United Nations and argued by disability advocacy groups for the last several years, especially in respect of medical assistance in dying. They went on to say a social assumption might follow, that it's better to be dead than to live with a disability, and that people with disabilities may decide to end their lives because of broader social factors, including, and this is where we go back to the social determinants of health, sadly, including loneliness, social isolation, and lack of access to quality support services. They also said, and I totally agree with them here, this isn't my voice, this is the voice that the United Nations has heard. From 3 special rapporteurs, insufficient attention was given to the voices of persons with disabilities. We were singling out the suffering associated with disability as being of a different quality and kind than any other suffering. So they concluded by saying that the amendments, which are now law, which they were trying to stop, those amendments would further the devaluation of life with disability and would reiterate ableist stereotypes that significant disability can be worse than death. It would result, and it has resulted, in a 2-tier system where some people get suicide prevention and others suicide assistance based on their disability status and specific vulnerabilities. And they concluded, again, it's not my view, although I happen to agree with them and delighted that they've weighed in, although our parliament didn't listen to them. They said that the threat to the lives of persons with disabilities proposed by the legislation was real and significant. Now, the Parliament of Canada heard from the international community. The Parliament of Canada also heard from disability rights organizations. And I present you with a sample. As it happens, these are organizations that I've worked with directly as a volunteer, as a member of the board, as a special advisor. So, I announce my allegiance right away. They have the same point of view that I do, and I have the same point of view that they do. But it's very important that they made these views amply clear to Parliament, and Parliament did not listen. Which they are required to do by the CRPD and by basic principles, nothing about us without us. So People First of Canada, of which I'm now an advisor, People First of Nova Scotia, said we are against the law that allows ending a life just because a person has a disability. People with disabilities are not suffering from having this disability. And look at what People First said. This is an advocacy group of people who do have disabilities, intellectual disabilities. Please vote to kill the bill and not us. The Canadian Mental Health Association said we're deeply disappointed that they strongly opposed MAiD for those with mental illness as a sole underlying cause. They say mental illness is different from other illnesses because we know that in the best of worlds, the symptoms may resolve. Inclusion Canada, which advocates on behalf of people with intellectual disabilities as well, said we must avoid sending the message that having a disability is an acceptable reason to be put to death. Lives featuring disability, frailty, and suffering can be lives worth living, and we should restrict access to those at the end of their natural life where suffering is intolerable, which is what the Supreme Court said, we said in our earlier version of the bill. So I'm also giving you here, and Nadia mentioned, I'm not in the closet about my advocacy here. This is one of a few editorials that were written by us, professors me and Grant and Sheehy as well, in National News Watch. We said that the bill would deny people with disabilities equal protection of the law. We said, from our legal perspective, that Canada was riding roughshod over its international obligations. We condemned MAiD, the Justice Minister, and Prime Minister Trudeau, because they've decided to make death available first, and then think about whether we want to fix the other underlying societal problems that make death the only choice for some Canadians. So they were reversing the order of priorities looked at from the perspective of the international community and our international obligations under human rights treaties. We said we have to lower our heads in shame nationally and in the United Nations. Our other editorial, and I also appeared before the Senate and wrote the Minister of Justice and MPs and so on, an exercise in banging my head against the wall, I can assure you, for the most part. But anyway, our editorial in the Toronto Star said that Bill C-7, which is now law, exposed the shallowness of our commitment to human rights of persons with disabilities. People do not die from mental illness. Instead, they are at risk of dying prematurely due to poverty, poor health, human rights violation, and homicide, including by police. Social, economic, and environmental factors, as well as inequalities, play a huge role. Offering death should never be our response. We condemn people with disabilities to live in poverty, unemployment, homelessness, and so on. As the Supreme Court has said, it's not just our view, right? And the message is clear that after relegating people with disabilities to the margins, after our broken promises, we offered people death instead of a good life. So that's the end of my message. That's why I say this is a dangerous trajectory. That's why I'm hoping that the disability advocacy organizations, of which I'm a member of and with which I'm affiliated, they're going to continue opposing further liberalization of MAiD to just permit you to be killed merely because you have a mental illness. And they will ask for the courts to step in and strike down what we've got. But there you have it. There's why I say we're at a dangerous point in our history. And that's why I say as well that the international community looks down on us now, and we ought to be ashamed of ourselves as Canadians. So there, stop, share, and now I'll let Dom and Nadia and you either clean up my mess or ask questions or tell me that I and the United Nations Special Rapporteurs and the disability advocacy organizations and my fellow scholars are just full of it. Go right ahead.
We are not going to say that, but thank you so much for helping to explore and expose this very troubling trajectory. After 2 sessions about how social workers should implement the new guidelines and changes, we felt that addressing some of the issues specifically that our Social Justice Committee is working on addressing as well, in terms of how do we help reframe mental health as not a biomedical issue, but a social justice issue, was an important responsibility that we had. So I am going to now share my screen, and I'm going to invite Dominic to, whoops, sorry, 1 second, to lead us in reflection on this very important conversation. And Professor Kaiser, thank you for outlining some of the legal history and implications of this legislation. And I will now be quiet and have Dominic continue.
Thank you, Nadia. And definitely, Archie, thank you very much for your passionate and well-informed perspective on these issues. I did read the editorial that you had published in the Chronicle Herald some time ago, and it certainly affected my thinking on this and got me to think more about it. And that's why I'm involved with this issue, as I have similar concerns to yours. From a social work perspective, there's several items in our code of ethics that I want to call people's attention to. So for the next slide, please. So the question is, why is mental illness treated differently from other health problems that qualify for MAiD? We need to be clear about this. Is the suffering of a person with mental illness qualitatively different and than, say, someone who is suffering with cancer? We know that the mental illness doesn't kill people. We know that the social determinants of health and the way people with mental illness are expected and forced to live sometimes in our society are probably the main reasons why they may wish to seek MAiD. So we need to be clear around how we view the type of suffering and how it qualitatively affects people's lives. The next step, or next slide. We as social workers believe very much in informed consent. And yet when we're talking about mental illness, the capacity to provide consent is going to vary quite a bit. And particularly, we need to be concerned about how certain mental illnesses feature suicidal ideation as part of the symptomology. Any of us that work in the mental health field know that people with ongoing depression are kind of divided into two camps. There are those that think about suicide and think about it often, and there are those that don't. And we have evidence that a lack of serotonin produces suicidal thinking. We also have evidence that certain medicines that are prescribed for depression, for instance, sometimes induce suicidal thinking. So how do we clarify whether the request to die is simply a feature of the disease and not something else that comes from the person freely making a choice for themselves? And when we talk about psychiatry being involved, because probably that's who would be making these decisions, the person requesting MAiD would probably be referred to psychiatry. So how does a psychiatrist assess these situations? It would be a very thorny issue for them to figure out, is this person freely making a choice here, or is this person making a choice as a result of the illness and its effects on the person's brain functioning? And as Archie mentioned earlier, the medical model that drives this would be problematic. We as social workers would want to see the whole person and understand the whole person in their social functioning. What type of society are they living in? That ecological model is an incredibly important piece in understanding how informed can the consent be of the person requesting MAiD. The next slide, please. We as social workers always need to be concerned about social justice. It's a fundamental in the work we do. And we know, and Archie has spoken very well about this, how people with mental illness are often more or less condemned to live in poverty. They lead difficult lives, they're stigmatized. And so these are the factors that might lead a person to want to die. And is MAiD therefore the answer? We have noted in the public purview recently how people with severe mental illness were kept in hospitals for many, many years, and provision for them to move into community residences and have more of a life was not allowed. And only recently has this issue really even come to the public's awareness. But we know that having a severe mental illness can be punished by unnecessary hospitalization. So that's an example of how a person may, you would understand they may want to die because of being more or less imprisoned in a hospital. But is MAiD the answer? Or should we be looking at providing people with a much better life? Again, echoing what Archie was saying. So I'd like to go to the next slide then. So one way of thinking about this is to consider this scenario. You have a client you've been working with, they have chronic depression. This person has attempted to die several times. They still want to die. They're afraid to try again because they might not succeed in killing themselves. They might end up in worse shape. Therefore, they want to have a treatment that would actually ensure that they will in fact die, and they want MAiD. How do you respond? I did have a client who fit this criteria actually. And I was not able, because social workers aren't allowed to counsel a person to die. I told him he'd have to take the matter up with his doctor. But it's something to think about. And how would you respond, and what would be an effective and helpful social work response to that request?
And so
I'll just make a couple of points whenever you have give me 30 seconds.
Yes, absolutely. Thank you so much, Dominic, for helping to sum this up and inviting us to reflect on what this can mean to each of us concretely as social workers. Please, Professor Kaiser.
Well, I just want to be very brief. I didn't, dive down into the weeds of the criminal code because it's not that kind of seminar. I do that elsewhere. But where death is not foreseeable, there's an important social work role, which I think is underestimated with regard to people who may seek assistance in dying. And specifically, if you do want to dive down, it's section 241.2, subsection 2.1 G. So what does it say that involves you? It says before a person whose death is not reasonably foreseeable, the person who is going to inflict death upon them, the medical practitioner or the nurse practitioner must, and I'm quoting here, ensure that the person has been informed of the means available to relieve their suffering, including, where appropriate, counseling services, mental health and disability support services, community services, and palliative care, and has been offered consultations with relevant professionals who provide these services or that care. So that's a fundamental obligation of the person who administers MAiD, that they can't do it until people like you are consulted, in my view, to ensure that the person who wants this remedy to their existential suffering, as in Dom's question, that they have benefited from every possible resource, to enable them to live a life for which they will no longer despair. And the final thing I'd say is that right now, a person with depression only is not eligible for MAiD. Remember, that only kicks in after 2 years, but it's on the horizon, and this government seems enthusiastic about it. So sorry for the intervention, but I didn't want to spotlight the role.
No, thank you so much. And I appreciate that, because this is the intersection of different policies, right? So we recently published our report with the Dalhousie School of Social Work on repositioning social workers in mental health. And we have consistently talked about how social workers have been sidelined because of this purely medical model of looking at mental health. And when we think about the medical model, we think about the funding that goes to support that, which is pharmaceutical companies, right? And so when we are looking at the sidelining of social workers and the lack of treatment options for people who have mental health issues, which we are working on, which is a tremendous problem in this province and in this country, that it's easier potentially for someone to get it will be, when this comes into place, easier for someone to get an appointment to die than an appointment to get counseling and services. The kind of services that are reimbursed are minimal at best, short-term crisis. There's a focus on reducing wait times, but there isn't an examination of the many psychosocial determinants of health that factor into the ways in which people who are struggling with mental health and disabilities are struggling to try to find ways to improve their quality of life. Furthermore, of course, the challenge is that many of the people who struggle with these issues are have intersectional identities and are dealing with other social justice issues and policy issues. And so when we put all of those factors together, the ways in which this legal change has been made without adequate attention or dialogue on the part of all of us is one of the reasons why we wanted to offer this this session, which of course we have 7 minutes left for people to share any questions or comments via chat that they might have. But this is a larger issue that our Social Justice Committee is wanting to work on addressing. It's almost like if we could have like a clock that's ticking for how much time between now and when these changes to MAiD are about to become visible and applicable. We have to transform our mental health care delivery system, the ways in which we provide support and services for people who do have different abilities or disabilities. And we have to address the social justice concerns and redefine mental health as something beyond a biological issue. On Monday, we're going to be talking about transgender mental health. And that's a great example of rates of suicide that are significantly higher than the average population, and the ways in which the absence of policy to support people in getting gender affirming care and getting their rights, basic human rights recognized, translates into severe psychological distress. And then if you have a policy, just like Dominic suggests, what is the role of the social worker? We are looking at guidelines and standards. We can do that with the way it currently is in place if there's an imminent death. But when this expansion, you have people in the medical assistance and dying team who are not trained to deal with psychiatric conditions because of the split in our healthcare system between mental health and physical health. These are all really important issues. And one of the reasons why we as social workers need to continue to advocate. We partner with the Canadian Association of Mental Health, and we are working on a process to help get a variety of different stakeholders to be able to speak with Brian Comer and our new government. This is both a provincial issue and a national issue. The Canadian Association of Social Workers is also working on addressing some of these issues, and all of us, by being members, are supporting this effort, but there's a lot more that needs to be done. In the 4 minutes that we have left, Professor Kaiser, thank you so much for sharing your knowledge, expertise, and passion. Do you have any words of advice for social workers who might be concerned about this issue, ways that they can get involved in advocacy to work on addressing some of these concerns that you raised?
Well, I'll make a couple of points very succinctly. First of all, so much is entrusted to the discretion and professional judgments of medical and nurse practitioners that I am hugely mistrustful, I regret to say, of their knowledge and expertise with respect to what they must ensure people know about. As I mentioned, under the criminal code, there has been appropriate counseling services, mental health and disability services, et cetera. I'm concerned about what I would call, the inertia of motion. The force of motion. That is somebody who says, "Oh, I want MAiD." I don't know that the people who provide these services are likely to appreciate that the precursors to somebody asking for that who has a mental illness may be these kinds of broad existential problems, where they haven't been given adequate supports ever and they're living in poverty. So there may be inertia of motion to keep that train moving, which is very dangerous. In terms of the social work role here, I mentioned you have a critical role in ensuring that those services have actually been delivered, and you should be insisting with the medical and nursing associations that the social work role is acknowledged, as an essential input into MAiD now for people whose death is not foreseeable. So you should liaise with those other professions. When it comes to the further liberalization of the law to permit people whose sole underlying problem is mental illness, then social work, in my view, provincially and nationally, ought to have an advocacy role before the Parliament of Canada, liaising with other disability advocacy organizations, saying, please put the brakes on this, and this is why you should. But you have huge support now, from the international community, from the special rapporteurs that I mentioned, from the United Nations Committee on the Rights of Persons with Disabilities. This doesn't just have to be your position. It's not my positions exclusively, right, although I agree with it. In the international community, there's a wealth of support for exactly the kinds of stances which I'm taking, but which I think you ought to take as well. So in some ways, you can just reiterate what's said in the international setting and say, you have to listen to what disability advocacy organizations are saying. I could go on more, but because I think there's a very important role for social workers to advocate individually and as an organization.
And for that reason, we will continue to try to make sure that our voices are heard. This is one of the reasons why, when we are talking about the changes to the Medical Assistance in Dying Act, it's important for us to think about the social justice and ethical implications of the recent change. And so while on the one hand, our first two sessions were specifically addressing with the current guidelines that we just updated, how should you handle it? Dominic gave us a really good example of a third type of example, which will become reality in the next couple of years. What happens if we have a patient who is suicidal, experiencing suicidal ideation, and is dealing with significant depression and is not able to get the psychosocial treatment that they need? How do we advocate for them? Do we simply refer them to medical assistants in dying nurses and doctors who may not have the training to address and assess appropriately some of this component? Or should the most ethical next step be that we work on advocacy and education and awareness, so we don't just learn how to implement uncritically certain laws and guidelines and standards, but we also maintain our critical thinking and social justice advocacy, which is a central part of what it means to be a social worker. So with that, I want to thank you for providing some food for thought. Hopefully this will enable us to continue to think and debate and dialogue together and continue learning about this complex law. And we look forward to hopefully everyone getting more involved in our social justice advocacy. But for now, Professor Kaiser, thank you so much for sharing your wisdom, knowledge, and experience with us. And Dominic, thank you so much for helping us begin to reflect on how Professor Kaiser's research and advocacy might apply to us as social workers. And thank you all.
Thank you. Thank you, and thank